Hey everyone, we're just going to give everyone a second to join our webinar. Hop on, let your friends know to hop on. If you're just joining us, we're just giving everyone a minute to hop on here. Hop on, let your friends know to hop on. If you're just joining, we're live. Okay. You ready, Ingrid? Okay. Hi, everyone. Thank you for joining us today for this webinar. I'm Amy Weimer. I'm the marketing manager for Desert Harvest. And it's my pleasure to introduce you to pelvic floor therapist and author of the Musculoskeletal Mystery, How to Solve Your Pelvic Floor Symptoms, Ingrid Harm-Ernandes. And Ingrid, we're going to start with you just telling us about yourself and how you got started in physical therapy and what inspired you to write the book.
Thank you. First, I want to thank you very much for having me and hosting this webinar. I usually get very excited about, talking about information to do with the pelvis because so many people are, reticent to talk about it. They're reticent to use the words and instead say down there, what's going on down there. So I hope this really opens up a world of information that people feel more comfortable in getting help and even talking about these issues. So I really appreciate the opportunity to do that. As far as me, I have been a physical therapist for about 37 years and specialize in pelvic health for about 25 years now. So just a little bit of time in the pelvic health realm. When I started as a PT, there actually really wasn't very much known about pelvic health in the PT realm. And it was a little bit difficult to get in. But what happened is I started treating my obstetrical patients. So when they were pregnant, they'd kind of whisper to me, hey, Ingrid, I'm leaking. And I'd be like, what is this leaking? What does that mean? And I'd have to, so I'm dating myself, kind of run to the library and look things up and figure out that, oh, that's urinary incontinence. And physical therapists in other countries are treating this. So I had enough information to kind of start the ball rolling with these patients and saw some beautiful results, even with just a little bit of work with them. And they were so appreciative of not leaking on themselves and feeling like something wasn't terribly, terribly wrong. And then with easy enough effort, they could help themselves. So it kind of grew from there. It took tons of courses. We now have what's called the WCS, which is a women's certification through our national organization for doing pelvic health, which includes men. So it's not just women. That's kind of a misconception that we just treat women. We do treat men. We treat children. So it's a pretty big realm. I mean, pretty much anybody who has a pelvis, we can treat them. So it gives us a lot of opportunity to treat a lot of different conditions. And then over time, when I was working at Duke, I was able to be a mentor and a residency director for our women's health residency program. So over time, it just grew and grew. And now I enjoy doing presentations and conferences. Wherever I can get the information out is kind of where I've gone. And then as far as the book is concerned, I think I was inspired most by my patients who sometimes had to wait 5, 10, 20, and sometimes even 30 years before they would see me. And simply it's because nobody knew that physical therapy existed for it. The physicians didn't know how to recommend physical therapy for them, and they didn't even know how to ask to get help for these problems. So I was really, really frustrated that it took so long, and my patients were begging me to write a book. And I really was trying to figure out how to get the time to write the book when Heather Florio came along and said to me, Ingrid, you need to write this book. And she kind of gave me the kick in the butt that I needed to write the book and a lot of support, and still gives me tons of support in getting this information out there. So I have Heather to thank for, really getting me going. And like I said, kicking me in the butt when I needed it to get this going. So it's an exciting journey for me to teach people in a different capacity, being an author, not just clinically working.
That's awesome. So your book is titled The Musculoskeletal Mystery, What is the mystery?
It's a mystery because most people just do not relate the musculoskeletal system to the pelvis. And what I mean by that is people think, well, I've got organs and I've got hormones, and I know that, when I menstruate or when I go through menopause, all these things are affected. And people don't even know that there's such a rich group of muscles at both our pelvic floor and our pelvis. So what I mean by that, you see a nice illustration below about the pelvic floor itself. And you can see there how many different muscles are just in our pelvic floor alone. The group of muscles is called the levator ani. And within that, there are smaller muscles that each have different jobs. And those jobs can be anything from what we call sphincteric, which means controlling urination, bowel movements. It can be sexual, so it helps us have orgasms. It helps us enjoy intercourse. It allows us to have intercourse. And then it's supportive, which is huge. So supportive is kind of, if you think of it, if you look at that picture, it looks a little bit like a bowl or a hammock, right? And think of that bowl or hammock holding all your organs up through your whole life. So sneezing, coughing, lifting, pregnancies, I could go on, right? You have this tremendous support system below, yet it can get abused just like any other structure in our body, and the muscles can become weak. They can become loose. They can become too tight, right? So we often say an overactive floor for muscles that are too tight, or an underactive floor for muscles that are too weak. And you can have a little bit of a mix of both, believe it or not. You can have a weak floor and a tight floor. And that sounds counterintuitive, but the way I like to really discuss with my patients how that can happen is, if you imagine you curled your biceps, right? And you held it really tight. After 24 hours, you can imagine that muscle's really tight and sore, and you maybe even have trouble pulling it out, and someone needs to have you pull it out. Now do that 24/7. And after a while, you start to lose strength because you're not using the muscle the way it should. It's not functioning the way it should, right? So this muscle's now really tight, uncomfortable, painful, but it's weak. It can't do its full job, right? So this is where a lot of folks get into big trouble, because they can have pain and they can be weak, right? And a lot of my patients actually fall in that category, this combination of issues. So it's a mystery because people are not able to take the first step of knowing the muscles are involved, because no one's there to teach them, right? So I'm hoping the book can do a really, really good job of teaching them what the muscles do and how they can even impact your symptoms, which the book does a good job of relating symptoms and diagnoses to the muscles and what the muscles are doing. If I take it one step further, that pelvic floor does not work as its own entity. And what I mean by that is it's part of a team. So our pelvic floor is kind of the most important part of the core and the hip musculature that works with it. So we have a pelvic floor, we have hip muscles, we have abdominal muscles, we have back muscles, and we have our diaphragm, and our diaphragm's a muscle, right? So it's kind of hard to imagine, but it's a muscle. And now think of the diaphragm being on the top of the canister and the pelvic floor being on the bottom, and they work together beautifully as a unit. So as one works, so does the other, and they influence each other. So if we do things like hold our breath, or have difficulty breathing, or don't really know how to take a true diaphragmatic breath, it impacts our pelvic floor. If our pelvic floor is tight, we may not be able to move, and you have that full functional ability of both diaphragm and pelvic floor together. Now put together your abdominals and your back muscles as that full core. And I like to relate it to your house, right? So your pelvic floor is the foundation of your house. The diaphragm is the roof of your house. The abdominals are the front of your house, and the back muscles are the back of your house, right? So if you pull the foundation out from your house, you can imagine you're going to have trouble with your house, right?
Yeah.
So I really want you to think about that, and how that whole core in that picture you see below really needs to work and function together as a unit. And physical therapy really looks at that entire structure in order to really be able to resolve issues within the pelvic floor and the pelvis. So you can kind of see how the musculoskeletal mystery expands beyond just the pelvic floor, but actually really encompasses the whole pelvis. And we often need to look at every one of those structures in order to help someone, not just, oh, I'm only going to look at the pelvic floor and nothing else. So hopefully the book will help people really figure out what that mystery is, and then take the next step is, how can they help themselves with these issues? How does it relate to their issues?
Yeah, I love that analogy of the house and how it all works together. That makes such a picture in our heads of how this is all coming together. Can you also share with us the types of conditions that commonly occur in the pelvic area?
Yeah, great question. So things that people think of, I think a little more commonly might be urinary incontinence. Losing urine when you don't want to sneeze or cough, or running to the bathroom. I can't make it to the bathroom on time. Fecal incontinence is, I call it the ugly stepsister of urinary incontinence, because people don't want to talk about urinary incontinence. They don't want to talk about fecal incontinence. And the shame of that, it's a lot more common than people think, right? So you're not alone out there when you're dealing with issues such as urinary incontinence and fecal incontinence. Then we have something called prolapse. So prolapse happens when there's a lot of force on the pelvic floor, and the organs actually start to do a little bit of a pressure downward. And sometimes you can actually feel a bulge at the vagina. And people freak about it because they feel like, I have cancer, right? Or something else dramatic is happening. And I tell folks, yeah, you definitely want to have your urogynecologist or your OBGYN look at this. But a lot of times, especially for women postpartum, that's a big time that it happens. And then during menopause, those are the two biggest, but it can happen at any time in life. And it can be of different organs. It can be of your bladder. It can be of your uterus, of your bowel. So that's prolapse. You can see that's a big category on its own. You have your pregnant folks. So during pregnancy, a lot happens. And unfortunately, women are usually told, oh, that just happens during pregnancy. Live with it, right? And that's so frustrating. You should not have to live with back pain during pregnancy. You should not have to live with shoulder, neck, and upper back pain. You should not have to live with urinary and fecal incontinence during pregnancy or after pregnancy. If you go to physical therapy during pregnancy, a lot of times these problems can be immediately stopped, and you can prevent them from occurring after pregnancy and even beyond. So it's not true that during pregnancy you might have the problem and it will go away. For a lot of women, actually, the problems continue after pregnancy. So we want to capture it during pregnancy to reduce what happens postpartum and even later in life, 30 years later, where the problems during pregnancy are showing that they do show up later in life as well, right? So we want to be a little proactive, is kind of what I'm saying with that. And then we have pelvic pain, which is a huge category. That can be pain with intercourse. And that's another topic that people just don't want to talk about. They have pain, they kind of just grit their teeth, they make it their intercourse, they don't enjoy it, or it gets so bad that they can't have intercourse. And that can be very disruptive to a relationship. So I have a lot of women who come to me where their relationship is ready to break apart because they cannot tolerate intercourse. What a shame, that it takes them a long time to get to me, where that should kind of be the first course of action. How do we get rid of that pain? How do we get someone to enjoy and have pleasurable intercourse by doing pelvic floor exercises and going to pelvic floor therapy? And we'll probably talk a little bit, I think, if we have a little time, a little bit more on what to expect with that. But I think it's a shame that women are dealing with these problems so long. And then for my guys, they also have pain with ejaculation sometimes. There's a condition called pudendal that can be both men and women. There can be pain abdominally after surgery, after C-sections. So like I was saying, there's pain in so many areas that encompass the pelvis that women and men do not have to live with. We can definitely help with all of these conditions. And those are just, I'm talking about the big picture of conditions. The book goes through many, many more, but it gives you an idea how big a scope, these conditions are and how many people suffer with them, yet, they're silent. They don't talk about it because they're embarrassed or don't even know where to go with it.
Yeah, and that being said, where do they go? Who can help treat these conditions?
Yeah, there's a team. So that team is extremely important. And what I'm just going to say before even talking about the big picture of the team is the patient, the person who has the symptoms, is the central part of the team. So it starts with the patient. The patient's recognition of what's going on and ability and knowledge of what's happening at their pelvis lets them start to look for the team. So in the book, we talk about all the different potential practitioners, and there are more. Again, this is like the big picture of practitioners. So it starts with physical therapy. That's my expertise. So I talk a lot about that. But you have urogynecologists who are very focused on the female urological kind of everything to do with the bladder and the pelvic floor and prolapse. They deal more with that. You have your OBGYN, which more people are aware of. That could be pregnancy and all female-related issues. You have urologists who, yes, they treat men, but they also treat women for all bladder-related and pelvic floor-related issues. You also have your family medicine team. So sometimes people don't feel like they can go to the family medicine practitioner, but they actually can. They do have knowledge. Some will do a pelvic exam. And that's actually a big focus. I just had a paper published this month in the FPMRS. It's the OGS journal, and it is how to do a comfortable, safe musculoskeletal exam for all medical practitioners, because I want patients to have comfortable exams. We need to start with those comfortable exams to discover what's going on. You then have listings of sex therapists, which are an awesome, awesome team member. They're the ones that will really help work with we do a lot of the clinical work, try to get them back to a point where they can have comfortable intercourse. But a lot of times there are relationship issues that come up, or even the person themselves doesn't know how to approach it with their partner. This helps them teamwork with their partner to get back to not just comfortable, but enjoyable intercourse. And that can be, difficult subject matter too. And I find sex therapists are awesome with this. Their massage therapists also can be part of the team. And then you have the entire mental health realm. So there are so many different practitioners out there. Some specialize in pelvic health, some specialize in sexual health. So there's going to be a big combination of sexual health therapists. And the book goes through a listing of how to find those practitioners. So in each one of the categories that you see on these practitioners, there's a little blurb on a website or informational site or patient information, or however it may be, that the patient can start to look up reputable, and I really say reputable, websites. And we have a little warning in the book too. Please be careful in searching Dr. Google, because there's a lot of stuff out there that you've no idea who's behind that. And can get some really wrong information. So I hope with the book, you can start with some more reputable and reliable resources that will help you on your journey to figuring out how to help yourself, for sure.
Yeah, so you mentioned physical therapy. What should a patient expect at a PT evaluation?
Yeah, that's super important. So my hope with the book is I've written it absolutely so patients can really read through this, so they can, help themselves, their loved ones, their family members, discussing it, getting it open. But I find that practitioners also need to know this, because a lot of times a practitioner will say, I think you should go to physical therapy, but they don't know how to describe what happens in a physical therapy session. So I hope that this description within the book really helps both practitioners and patients understand it. So when you go for an assessment, your therapist is going to do a very thorough, what we call a subjective exam. The subjective exam basically means they're going to ask you a lot of questions. So they're going to ask you, so even if you've come for urinary incontinence, they're still going to ask you about your bowels. They're still going to ask you about any sexual issues. The reason being is someone sometimes will come for, let's say, overactive bladder. I'll just pick a diagnosis. And they're really having bladder issues. When I'm doing the subjective exam and I ask them, so have you had any pain or difficulty with intercourse? They're like, oh, I have, but I don't even know how to talk about it. And it's an indication to me, not only that we need to address it, but the pelvic floor is probably overactive, right? Remember before the discussion about an overactive or underactive pelvic floor, I want to know that that pelvic floor is overactive in more than just the bladder issue, but also in sexual issues. And we can help them. So just because they're there for overactive bladder doesn't mean I can't help them with other issues like constipation or overactive bladder. And constipation, by the way, is a big, big diagnosis that people think they have to live with, and they don't. And the pelvic floor and overactive pelvic floor has a huge influence on constipation. So, that's something that therapists can definitely help with. So we want to ask all of those questions. So before I ever even start working on the patient, I know a huge background, surgeries, anything falls. I also want to know, are they a mom with 3 children and a job, or are they a retired person? Do they have a lot of stressors in their life that super, super are influential on what's going to happen, not only with their symptoms, but what do I need to do as a therapist to help them get better? All right. So if they're a super busy mom, I'm going to have to understand they may be limited in the amount of exercises they can do. So I'm going to try to cherry pick with them what works best, right? So the therapist is really looking at a functional level, not a medical diagnosis to say someone with urinary incontinence comes in and they have the same exact diagnosis as the next patient in the door. I may treat them differently because they're different people, right? So the therapist is going to look in their exam to figure out what's their lifestyle and how do I help them within their lifestyle with their diagnosis. And then the second part is hugely important. So in the book, I talk a little bit about a 3-dimensional, like a plastic model that's just awesome for showing people, similar to the picture you saw a little while ago, what does the pelvis and what do the muscles look like? And I described to them what will happen with these muscles in overactive, underactive, what will happen with the abdominals or the back musculature when there are problems together. So by the time I even get to doing my exam, the patient has a full education as to what's going on. Then we do an internal exam for the majority of our patients. Now, I've got some patients where they may not be ready for their first exam. I encourage you to say, I'd love to do this, but I might not be ready on this first one. Can we maybe do this on the next time? The therapist will be fine with that. No worries on it. There's so much we can do in a session. The exam should be comfortable. Here's something that I tell my patients is no matter what pelvic exam you have, you need to speak up and say if the exam's uncomfortable. It doesn't have to be. Right, that's a big thing. So when we do an exam, it's different than what you get in OBGYN. No speculum, no stirrups. That often sets people at ease right away, just knowing they don't have to have that, right? We use a gloved finger, and we're looking for the musculature. We're looking at the opening. We're looking deeper. We're looking at all those lovely layers you looked at the picture before to determine, is there tightness? Is there weakness? We look at the muscle strength. We use something called the perfect scale. Basically, we look at how much power or strength there is. We look at how long someone can contract. We look, can they repeat that? Can they do it quickly? That gives us an idea of how the pelvic floor is functioning. So when we're ready to set them up with an exam, the patient knows, oh, this is what it should feel like. Now I know I'm doing a proper pelvic floor contraction. Now I know I'm relaxing it. Now I know I have pain here, and it's related to my symptoms. I've done exams where I find there's a hip muscle called the obturator internus, internally that, if I press on it, there's pain and it radiates out to the hip or the back. Then like, oh my gosh, that's duplicated pain I've had in the hip for years and nothing has ever helped it. And we do a treatment on the pelvic floor and the hip gets better. That just illustrates how working on the pelvic floor can actually help other symptoms and why it's important to know that we can also help back and help the hip symptoms. And I often tag team with my orthopedic specialists on hip and back problems because we can help them to such a great degree. So it's just great to know that you're going to go through this very, very specific evaluation with a therapist before they even set you up on what you're going to do, because knowing what the pelvic floor can do, not guessing at it or just saying go do Kegels, is not going to be helpful if you don't know how to do those Kegels properly.
And Ingrid, I have a sort of a side note question. So at Desert Harvest, we have a big, we help a lot of IC patients. Is there a different exam for an IC patient, or do you recommend physical therapy for IC patients? Just wanted to touch on that for our followers who are dealing with that and everything that goes along with it.
Oh, absolutely. So, IC is a big in the pain category that I mentioned before is one of the big ones in the pain category. So, oftentimes, interstitial cystitis is thought of, it's just a bladder problem, period. It's not just a bladder problem. It's a musculoskeletal problem as well. So in working with your team, there are many things that need to be done to help calm the bladder. But while that's happening, we really need to treat the pelvic floor, because chances are, if it didn't start as a pelvic floor problem with the initial symptoms, and this is the case for a lot of pain symptoms, it ends up being a pelvic floor problem because there's such guarding and tightness. So remember that overactive pelvic floor and the bowl I was talking about, those muscles get so tight that they become an issue all unto themselves. And they keep encouraging more and more discomfort till the patient can't get out of the cycle, even if the bladder's calmed down. So the therapist will still do a pelvic exam if it's comfortable enough, but will probably look at the bigger scope. So briefly, I mentioned we may look at, the hip or so forth. We're going to look at abdominal tone. We're going to look at back and muscle and hip tone. We're going to look at strength of that whole area. And then we're going to prescribe a program that includes pelvic floor, an entire pelvic for that IC patient. So we're looking at, and we're well versed enough that we can guide you a little if you're having trouble with dietary fluid intake and that kind of stuff. So the therapist will wrap that into the entire treatment plan. But I find a lot of my IC patients have kind of started on that journey, and then I need to help them really get on the whole musculoskeletal train and really start working on that as they're working on other things. And, I recently had an IC patient who was going through all sorts of things and could not make that traction. We started working on the musculoskeletal system, and her symptoms just really started to go down in a short time period. So it was the missing link that I wish so many people, it wasn't the last thing, for that missing link. It's an early intervention, right? So we can absolutely help our IC patients tremendously.
Oh, that's amazing. And what can we expect for physical therapy treatment? Can you explain that a little bit?
Absolutely. So physical therapy treatment I'll start with saying it's extremely comprehensive, and that it is a little bit different for everybody. So looking back to what I was saying about the functional level and someone's different lifestyles, right? So we need to take our knowledge base and basic things we'll do and fit it in the lifestyle of the patient. And that's why therapy can be different. So don't expect that you might be going in and another patient may go in, or your friend may go in with a different therapist, and the treatment may be a little different. It's probably because your lifestyles are a little bit different, right? So we can't anticipate that it's going to be exactly the same. However, there are basic things that every therapist will do. So I'm going to start with the pelvic floor because that's ground zero. So the pelvic floor, after your assessment, that therapist is going to say, for example, well, you can do a 2-second hold, but it takes you 6 seconds to let that pelvic floor go. Well, I'm not going to ask them to do a 10-second hold and a 10-second rest, because they're going to tighten their pelvic floor more. They're going to fatigue their pelvic floor. They're going to have pain, and they're going to say, Ingrid, I'm never doing that again, right? So what we have to do is base our pelvic floor exercises. And notice I use the word pelvic floor exercises. So with my patients, once we start and we use the word Kegel in the first assessment, just so they know what I'm talking about, I don't use the word again, and I ban it from my clinic. Same with my residents and my fellows and all who follow me, because there's such a misconception of a pelvic floor contraction and relaxation. And we want that pelvic floor exercise to be extremely specific to what the patient can do. Once we establish that, then we look for progression. Can they start to hold longer? Can they rest better? Can they do more over the course of the day? Can they do it in different positions, right? So there's a lot of fun things that we can do. I've had patients practice pelvic floor exams while they're doing things like playing a trumpet, doing their sport, so that it relates to their functional level. And again, that's going back to how important that is to know, what is that patient doing every day? And am I doing something that's going to help them in their everyday work or home life? Or am I doing things that's going to be counterproductive, right? So that would be like square one as far as your treatment is concerned, is a very specific prescribed pelvic floor exercise program. And then we can move out from there. So some of the other things that we might do is exercise prescription for the entire pelvis, diaphragmatic breathing. That's a huge one, right? Diaphragmatic breathing seems like, how could something so simple, help so much? But if you look back at that, before what I was talking about with the breathing, right? Every diaphragmatic great breath you do impacts the pelvic floor. We want to make sure that that breathing is helping the pelvic floor function better, that the breathing is helping calm the system down. So a lot of people have heard of the flight and fight mechanism, which is basically, way back from nature, if an individual saw a predator, we would have to consider, are we going to fight or are we going to run, right? And our body still does that to this day. When we diaphragmatically breathe, we tell our body we're going to calm down out of a situation like that. If someone is always in pain, if someone is always stressed, they're breathing short, and that short says, I'm ready to fight, or I'm ready to run, and the whole body remains tense to the point that the person doesn't realize that their whole body is tight like this. Diaphragmatic breathing can help reverse that. So we often use diaphragmatic breathing for our pain patients, our overactive, IC patients can do very, very, very well with diaphragmatic breathing. So the picture you see below is just kind of an example of a starter resting position you might try with diaphragmatic breathing, focusing on the ribs opening up and then progressing to doing it different ways. So that's another possibility with exercises. And then there's strength exercises, there's stretching exercises, there's so many different exercises we can prescribe. Then we do what are called manual techniques. So manual techniques are, there's a big range of manual techniques. So it could be soft tissue work, or we're trying to get in there and we're trying to soften the tissue up and get it to function better. Mild fascia release, we're trying to get the fascia, which covers muscles, organs, everything in our body, to function better, improve muscle flow. So that's another important technique. I personally don't do dry needling. That's another technique you can do to get the muscles to relax out and to calm down. There can be manual stretch techniques. I could go on and on. There's so many manual techniques, and the book really goes into detail, on the techniques you can expect. There's something called biofeedback. So biofeedback, we use a unit that will help us determine the activity of the muscle. So what I mean by that is there are little sensors that we use either externally or internally that the person will have vaginally or anally that lets us look at the muscle activity. And it lets us look how well someone's contracting or relaxing. So if we do that, we can really see, and the patient can see on a monitor how well they're contracting and they're relaxing, right? So it can mean that as they see it on the monitor, they can see the graph go up, knowing they're doing contraction, the graph let go. They can see how well they can rest. Are they not able to get into a decent resting rate? And we can work through, sometimes it's auditory, sometimes it's visual kind of techniques to help that patient learn how to relax their pelvic floor. So it's a great tool that helps the patient understand better what their pelvic floor is doing. So that's yet another technique that we can use. There are, like I said, so many different techniques. Those are some of the biggest ones that stand out, that really say, oh, okay, so if I go to a therapist, I would expect either manual techniques, stretching techniques, pelvic floor exercises, a bigger group of exercises, biofeedback. Those are just some of the hitting the tip of the iceberg on the different things that you could potentially expect within a treatment.
Okay, so while they're waiting to get in treatment, are there things that can be done at home that could help aid some or give some relief?
Yeah. So the book has some great self-help techniques. And I wrote it there because I understand that many patients, it may take them a while to get in with a specialist, get in with someone that they think may help them. And I want them to be feeling that they are empowered to be able to help themselves. So by having the knowledge base and then having some things to start with, they can start their road to recovery. So before I mentioned diaphragmatic breathing, since I think that's such a big thing that so many people can really, really help themselves with, that's such an easy thing to do wherever you are. You don't need special equipment. You need your diaphragm and the ability to breathe, right? So what I start my patients with, and I'm going to clarify here. So many of you have probably heard the word diaphragmatic breathing, and you'll see a lot of information out there about belly breathing and trying to blow your belly up. Well, unfortunately, that's not particularly accurate. Really, our diaphragm is under a rib cage. So I tell my folks, you can easily, in this position you see in the picture, put your hands around your rib cage. And when you put your hands around your rib cage, no matter what position you're in, but I do recommend lying down at first so you can be super focused on what you're doing. When you breathe in through your nose, you breathe in slowly, trying to expand your ribs under your rib cage. So you can even try it now if you want, kind of getting your rib cage to open up. Your belly will naturally expand with it, but I don't want you to force your belly. When you force your belly, people inadvertently sometimes put pressure on their pelvic floor, and we don't want to do that. We want the rib cage to open beautifully. And then once you feel like you've got that full expansion, that should take at least 4 or 5 seconds to get it out there. You want to blow out through your mouth. Enough at first that you can hear it. You don't have to hear it over time, but in the beginning, I recommend it so that you take time blowing out slowly, feeling the rib cage kind of sink down and collapse back under your hand. So if you try it slowly like that, and you should be blowing out. So you see how long I took to blow it out?
Yeah.
Take your time. You really want to do that so that you have the feeling like your body is just kind of settling down and relaxing. Over time, you can practice that anywhere. You could be sitting in your car and frustrated at another driver and take a diaphragmatic breath. It's amazing how you can get your system to calm down. You could feel like, I'm ready to have an argument with someone. Take a diaphragmatic breath. It's a great way to kind of collect yourself and realize that maybe you're getting stressed over something that you actually don't need to be stressed over. You have some clarity come in sometimes when you take the diaphragmatic breath. So I recommend to my patients to do at least 5 or 6 breaths in a row. You can practice a minute or 2. It really depends on, some people get frustrated if they have to count. So I said, go put a timer on. Some people don't like timers, so count. Or just do it until you feel relaxed. I don't want you to feel like it's another stressor in your life. I want you to feel like you can actually help calm your system down and reduce your pain, by doing the breathing. So that's one great self-help technique. Another one is at the pelvic. Oh, I'm sorry.
I said, I love that.
Yeah.
I tell my daughter, like, she gets a little worked up. I say, take deep breaths, but I have to show her this technique because it is very calming as I was doing it with you. So I'm definitely going to pass that on to her.
Good. I'm hoping the audience, has a chance just to practice it because it's just it's a cool thing to do anywhere. And like I said, you don't need equipment. It's a great thing. Then as far as self-help, there are a number of different things to go through in the book that I think that would take a lot of detail to go through here. But I'll take a moment and talk about the pelvic floor because I kind of introduced it before when we were just talking about assessment and so forth. So thinking back to what I was saying about the pelvic floor and doing a proper contraction, what I'll describe quickly here to the audience is that a pelvic floor contraction needs to be specific to the pelvic floor. And what I mean by that is a lot of people will say, well, I'm doing my Kegels, and I see, they're moving their whole body, their abdominals, everything's going. Well, I say we don't need the orchestra. We need a soloist when we do this. We want the pelvic floor to be the person, to be the being that does the work in this case. And how do we do that? So the best description I give my patients is imagine you have a straw in the vaginal canal. And what you want to do is you want to pull fluid up through the straw with the muscles of your vaginal canal. So what you're doing is you're pulling up and in. Even if you keep the idea that you're pulling up and in, you're not squeezing, you already are long on your way to isolating the pelvic floor. And then you want to make sure you've let it go. So folks, don't try to do 100 of these in a row. You want to start by just getting the feeling that you can do them and then let them go. The therapist that works with you and evaluates will say, I'm finding that you're really struggling with letting go. So we're going to focus completely on letting go. If you've pain, you probably want to focus on letting go. You don't want to focus on a bunch of contractions, right? So I'm saying this with a huge word of caution, and I say it in the book too. I'm saying it so that you can understand there's an isolation and a better way to do a pelvic floor exam. But usually a physical therapist really needs to say to you, this is how you should do it for you as an individual, not a global, everybody should do it the same way, right? So you can see that the therapist is going to help you with that, but you can get an idea. If you've been doing Kegels like mad and squeezing away like mad, please stop squeezing. Just think of this isolated, and that relaxation often is so important to do before you start really trying to squeeze away, and think of pulling up and in, right? So those are huge as far as self-help techniques. In the book, we talk a little bit about overactive bladder and learning how to calm your bladder down. It's a little more extensive. The book will really go into the fact that you don't have to run to the bathroom. In fact, it's counterintuitive. That's the worst thing that you can do. The book talks a little bit about, with constipation, how do you eat right, drink right? What are the things that can influence it? For almost every one of the conditions, I'm going to say make sure you drink enough water. 64 ounces is a made-up number. It can be a ballpark, but really what you want to do is make sure your urine is not clear, but really pale yellow. And that gives you an idea. So folks, please make sure you keep your fluid level up. It's going to help almost every one of the conditions in your pelvic zone for sure, right? And that's a very basic, easy thing for almost anybody to do, for sure. And then I would say overall, there are some different tools that we recommend. And I'll mention the tools pretty simplistically because, again, that needs a lot of guidance. So the book goes over a lot of detail of things like dilators. All right. So what's a dilator? A dilator is basically a tool that can be a straight dilator, like you see the Soul Source. That's one brand that you can see out there. And notice they're of different sizes, right? So your therapist is going to say, well, we need to start at this size, move to this size. They're going to show you how to use it. They're going to show you to use it with lubricant. Use it with lubricant. I can't say that enough. So they're going to describe to you exactly how to use these tools. There's a secondary tool. I call them S-shaped wands because there are a lot out there. But there's a wand there are a couple ones that I do like to use. Easy Magic happens to be one of them. A lot of them will have like a little knob at one end, and you see the S, that curved. What that does is it lets you get around to muscles that's hard to get to with the straight wands. So the curved ones will let you get over to the obturator internus that I had mentioned before, because it's way over to the side. It'll let you get deeper into some muscles that might be at your coccyx. So these devices let you reach all the muscles and lets the person actually help treat themselves. So the therapist may say, okay, I'm finding these muscles are tight. This area is a problematic area. With this wand, you can actually reach that yourself. You can treat that in between our sessions. Because therapists generally, they might see their patients once a week tops. Every other week is very common. And then towards the end, maybe once a month. So you might start with treatments that are more regular and really spread out, because a therapist wants you to be the primary source of kind of your healing, right? So we guide you, and we want you to be able to take care of yourself. We want to empower you to take care of yourself. So there's a little analogy I have in the book. So my son flies planes. He's an instructor pilot. He's flown gliders. And a glider is basically a non-motorized plane that gets pulled up by a motorized plane. And once that plane is up there, and the glider pilot feels like they can go on their own, they release the cord and they fly on their own without an engine. It's actually quite an amazing sight to see. And they can do acrobatics, and then they just land quietly back on the ground. I think of the therapist as the tow plane. We get them up there, we get the patient going, and the patient is the glider, right? And they can do all these wonderful things over time and land safely on earth. And if they need to be towed up again and have help from the therapist, we're there, right? So that's kind of how I look at the therapist and patient role. I just want to kind of add that in there because a lot of times a patient goes in and thinks that they have to be told something, they need to follow it, and it all ends there, right? There's such teamwork going on between the therapist, the other team members, and the patient, with the patient being the center, like we talked about before, that, I really wanted to stress that's how important it is. For folks to realize how much of a team they are with therapy. I quickly mentioned a little bit about lubricants. So lubricants are important for using the dilators. They're important for intercourse, and they're important for daily use. There are a lot of lubricants out there. And I think I might call a little bit on Amy, one of our experts from Desert Harvest, to help out a little bit with some of the ins and outs of lubrication, and just kind of demonstrate how important it is for using in different ways, and why the importance is there, and why there's difference between lubricants. So Amy, I'll kind of let you start talking a little bit about that, if you don't mind.
So yes, we have our Aloe Glide. Some of you may or may not be familiar with this product. Our Aloe Glide mimics the natural pH of the vagina. And, many of us know, and some of us don't know, pH can be offset by things like soaps, lotions, intercourse, and that can really disrupt the flora and fauna of our vagina. Osmolality is one of the things we talk about in the book, and osmolality is how water flows through the cells. The optimal osmolality for a woman is 290, and our glide is 308, which is super close. If it's too high or too low, it can really destroy the epithelial cells, and when that layer is destroyed, you open yourself up to getting STIs and bacterial growth. So it's really important to consider all of these things when you're purchasing a lubricant. You don't want to just go to your local grocery store and just pick one off the shelf that has a pretty label. You really want to make sure you're paying attention to the label, and the osmolality, and all of that, what it's made with. Always check ingredients. So hopefully that is helpful for you guys. And ours is obviously available on our website. It has been on back order, but we're hoping to fulfill some orders soon.
Thanks. That's fantastic. It is so important, and I will guide my patients through the process too, because a lot of times they will use, lubricants that have alcohols and preservatives and all sorts of stuff in it, and they're wondering why their pelvic floor is so irritated. And the great thing about Desert Harvest products is they don't have that in there, right? So, I'm not worried about what my patient is putting on their pelvic floor. I feel confident, that they're using the best thing they can for the pelvic floor. So just read, research yourself. There's lots of information in the book on that too, that can really help you understand, the ins and outs of all of that. But thanks, that was very helpful to, to go through that and just look at why that's so very important.
Yeah, no problem. Now, wrapping this up a little bit, can you go ahead and give us your pearl of wisdom from the book?
Yeah, it's so hard for me to choose from the pearls of wisdom. There are some pearls of wisdom at the end of every chapter that if you open the book and you're like, oh, I'm not sure what's in what chapter, the pearls of wisdom are actually a way to find that you're in the right chapter for whatever subject matter you're looking for. But the end of the book has kind of tie it together, pearls of wisdom. And I think the one that I'll choose for discussing today is more or less like, get to know your pelvic anatomy. So what we started with today, I feel like if you know that anatomy, you are going to be a star when you go talk about it. And that is whether you go to talk to a practitioner or to your neighbor. And hopefully you're now going to feel like you can, because if you can talk to your neighbor, your sister, your aunt, your mom, it doesn't matter, your daughter. I want you to go out there and talk about it and feel like you're empowered. And this book, its purpose is to empower you to feel like you can talk about this and that you can get treatment that you need, or you can help someone else. I've had some people buy the book so that they can give it to someone else because they feel like it's hard to start the subject, right? I've had some of people I know give it to their physician to say, hey, please, can you put this in your waiting room? Because people need to be able to talk about this. They're so afraid to talk about it. Please, please do this. So if you are empowered to do this, I think that it's going to help us all really, really get that care and feel like we can finally start talking about these things. So that would be my pearl of wisdom to choose for today's discussion, and hope that I really can help people start down the road of feeling comfortable and start getting help when they should.
That's awesome. Before we open up to a Q&A session with our live audience, I just want to mention Ingrid's book. You can buy it on Amazon.com or on desertharvest.com. And also this video will be recorded and we will post if you missed all or parts. We're going to have it on Desert Harvest YouTube page. It'll be on Desert Harvest social media platforms, Instagram, Facebook, and Ingrid, I think you as well will have it on your page as well.
Yep. And Amy, I love that you have all of those little Post-it marks in your book. I love it. So we made the book lightweight and easy to carry, and easy pictures for that reason, that it's very portable and helps discussion. So I love it. That was perfect.
Yes, no, not planned at all, but yes, these are my go-to spots. So now we're going to go ahead and take some questions. If any of you have questions for Ingrid, and we'll just give them a second to see if any of them roll in. This has been fun. Ingrid, is this your first live?
I've done a few. I think, because the pandemic, it's really opened up the,
Yes,
doing it.
Yes.
Yeah. So it's interesting, to get used to, being able to, just talk. I'm used to, having the audience right in front of me, but it's been a blast, and people have asked, interesting questions, and I think we all are kind of getting used to the whole Zoom webinar, everything else, Facebook Live things
the
now.
new normal.
Yeah, and be able to reach an audience like across the country, so to speak, and eventually across the world. And that is something that I hope too is, that we can start opening up windows. I've talked to some people from England and from Turkey, India, who have a great interest in it. So it's good to see that across the world, a subject like this can unite people and get people to ask some great questions.
Yeah. And if no one does have questions, we are available to submit questions via Facebook to Ingrid or the Desert Harvest page. Ingrid, do you want to tell us what your Facebook page is? Is it the Musculoskeletal, or is it under your name?
You can find it under my name, and there's the Musculoskeletal Mystery page as well. So you can find me either way, and I post periodic some updates or some information, or if there's the paper that I mentioned, I haven't put that up there yet, but that's the next thing to put up there. It's a great scientific paper, it would be for more the practitioners, in the audience, but I think it's great for anybody actually.
Yeah.
And then there's a related material up there. And if we do any other webinars or interviews or anything like that, I'll try to post it up just so people can catch up, because I know it's not always convenient, or people are working. It's kind of hard for them midday, to hop on and so forth. So they might review it later in the day. So I'd be happy to, answer questions if people have things coming up later on. That's fine.
Yeah, definitely. And you can comment, and we'll do our best to, go through all the comments if they're questions and get those answered as well. So
And I think if there's some questions that I've had in the past that come up are how to find a women's certified physical therapist. And so we have a national organization called the APTA. And then there's the Pelvic Academy is like a subset of that organization. And if you go on that website, there's a PT finder, and what you can do is when you click on that, you do women's health specialty, and then you can put in your zip code, like let's say a 50 mile radius, and it will come up with specialists that are in your area, and that sometimes helps you find a specialist.
Yes, and I see a question that popped up. Desert Harvest aloe vera has been a huge help to me so that my symptoms are fairly mild now. Would I still benefit from physical therapy?
Yeah, depending on what your symptoms are. So, yeah, that would be like if you have pain on intercourse, absolutely 100%. If you've overactive bladder, irritation, or pain from IC, absolutely 100%. It sounds like you've taken a great step forward in helping yourself. And I think that the physical therapy link, that might be the missing piece for you, the piece of the puzzle that might help you with the remaining symptoms.
Very nice.
Yeah, and that's a great question, because a lot of times people aren't sure that if they've started on their road, and they still are having symptoms, they're not quite sure what to do about it. And that's a perfect question for a scenario like that.
Yes, and I love that this has opened up conversation, as you said, instead of referring to down there issues, that we can openly talk about our vaginal health and not be so ashamed of the issues, and not feel like you're alone. So I'm really appreciative of that, with this discussion and with this book and with Desert Harvest in general. It's a great community to feel like you can talk about your problems and get some questions answered.
Yeah, yeah. We were talking a little bit before how people are so reticent to, use words beyond down there, that it's very hard to say vagina, it's very hard to say anus, or, whatever it may be. And it is a shame. So the more we talk about it, the better that will definitely get for patients, and it will make them less hesitant to even ask, can I get help for this?
Yes. Do we have any other questions?
I'll add in, since people may ask question, another one that people tend to ask is about, physical therapy itself. So I was mentioning men, women, children, and then a lot of pelvic therapists also do lymphedema treatment, which is swelling of limbs after, let's say, breast cancer and a lumpectomy, or any kind of surgery within the chest area may produce a difficulty with the lymphatic system. So it's a lymph drainage therapy that can be done too. So just want to add in that, there's a big picture in there, and the book will list out some of those things too, so that you know how all-encompassing physical therapy can be for this area.
That's great. Okay. Again, you can buy this book on Amazon.com, desertharvest.com. Look for this video to be posted on social media, on YouTube, on Desert Harvest page, and also Ingrid's page. And thank you guys so much for joining us today. Thank you, Ingrid, for your time and answering all those questions for us. I know that the audience is going to look forward to reading this book. Grab your copy and do some shopping at desertharvest.com while you're at it.
Thank you again for having me.
All right. Take care, Ingrid.
Thanks. You too.
Thank you.